Hello, everybody. Welcome back to the podcast. Today, my guest is Dr. Mandy Rice. She is a general surgeon in private practice who also is going to be rolling out a direct care practice called Midlife Women's Health. It's a lifestyle hormone replacement therapy type practice that is meant to resource women in later in life. And I'm super excited to have you on the show. Thank you.
Thank you so much, Mel. I'm so excited to be here.
So tell us a little bit about your journey. I have a lot of questions about direct care, but before we get there, I want to hear about how you got into surgery and what your training was like and all of these things.
Yes, the long story. So I actually entered medicine in a very unusual, we call it non-traditional pathway. So I was actually a nurse first.
Okay.
Yeah, so I was raised in a very gender role specific household. So if you were interested in anything medically related, there was no option, really no thought even that I would enter medicine. It was you're interested in taking care of people, so you become a nurse, which turns out to be a great start to my career and has helped me for sure every day that I've been a surgeon. So I was about 22 years old when I finished nursing school and got into my first job. It was actually my only job in the nursing field. I was a pediatric ICU nurse,
Wow.
and that was wildly uncomfortable. And interestingly, about a month into my nursing practice, a pediatric resident at the time, now he's a pediatric cardiologist, he saw me coming to work early every day. I used to get there about 45 minutes early just to pour over the books, to look up the terminology, the medications my patient was on, the diagnosis. And I remember he was watching me for about a week coming in really early. And he stopped me and he said, "Okay, listen, I've been seeing you come in early. You're way earlier than the rest of your staff, and you're pouring over these books. If you were so interested in this level of medicine, the science behind it, why did you go into nursing school? Why didn't you go to medical school?" And I told him, "I am not smart enough to be a doctor." And his response was very interesting. He said, "So you think that people are smart enough to be doctors before they even get their training in medical school?" And I was like, "Oh, that doesn't actually sound logical, does it?" He said, "Just think about it." And so I did. And about a year later, I enrolled into pre med classes and was working full time as an ICU nurse and then taking classes part time. And so it was a long road to get there, but ended up getting into medical school and then, much to my husband's dismay, fell in love with surgery. It was my first rotation in third year, and I absolutely loved every minute of the chaos and craziness.
Yeah. What did you love about it?
I loved using my hands to be able to help something happen. I loved even something as basic as the anatomy and the tissue manipulation. I was fascinated by the diagnoses that we encountered and the fact that we could fix a lot of things. It was all very high stakes, very critical. I was used to critical thinking. That's what I did as a pediatric ICU nurse. And in the last 3 years that I was in the ICU as a nurse, I also was on the pediatric critical care team. And so we would use the helicopters or the small prop jets or the ambulances to go and either pick up kids that were really sick in other locations, small adjunct settings, gosh, sometimes even very rural settings at a makeshift hospital, that looked like it was just a building that was turned into some clinic space, and we would fly them back to our ICU and take care of them there. And so that required a lot of assertion on my part, a lot of ability to assess the situation with the patient, what their status was, and then intervene, even if it was intubating the patient or starting pretty significant critical care medications, and then communicate with my physician back at the ICU by phone.
Mhm.
And so that was a really critical time for me. I think it was the last 3 years that I was a nurse there. So I was in my fourth year when I started on that team, and then did it through my seventh year when I decided just to quit and pursue medicine full time. And those were wildly, I think, impactful in me becoming a physician, because I knew already that level of autonomy was growing, and my ability to communicate with the teams and work in such a high stake situation without the support that I was used to, being in a really highfalutin ICU. Here I am, and I mean, gosh, one time we were in a tiny little place in podunk nowhere in Texas, in a very small building that looked like it used to be a really old nursing home, and it was very understaffed, very it looked very sparsely, set up. And that's where I picked up the patient from. And I was like, wow, there's nothing around me. And so it really is one of those things where, you figure out that you like being outside the comfort zone and making things work, or you realize that you need to have the comfort zone around you. And so I surprised myself that I really loved it, and I flourished in that chaos, strangely enough.
That's so interesting. Yeah, no, I remember loving the chaos as well, and the autonomy
Yeah.
too. And just being like, wow, like
Yeah.
I like the buck stops with me. I get to make all the decisions and
Right.
life or death. And it's like,
Right.
yeah,
Yeah, and that's strange now, knowing what I know about myself now, looking back at what was attractive in that for me and understanding it at a deeper level than I knew at the time. Now, after, talking with different friends and coaches, and I realize now that I think what I liked about that was it was comfortable. Chaos was comfortable. I
mhm,
came from a difficult family,
yeah.
chaotic, dysfunctional home. I was the oldest daughter of a group of 7 kids. There was only one sibling older than me. And so I helped raise the younger kids because they were a lot younger than me. And I think that controlling chaos was something that I understood. It was something that felt familiar to me, if not comfortable, but definitely familiar.
Or safe, maybe.
Yeah, because I knew I could handle it. I had proven that to myself, and I knew that I could rely on myself to have my own back and to, push through difficult situations. So that was something that I felt like I could handle, but I didn't realize the connection until I got older. So here I was, choosing surgery because it was controlling chaos. It was using my hands to fix something. It was interesting anatomy, which was always so fascinating. I, I tell stories that are just so Texas, but so I'm from Texas originally. And I remember as I was figuring out that I liked anatomy, it was through really strange things. Like I would dissect the turkey heart at Thanksgiving and teach my family about, the chambers in the heart and everything. And then there was one time where I actually ended up doing I guess, a necropsy on a snake. My husband, okay, this is such a Texas story, but we had heard in the rafters outside my husband's office, we had heard just a squawking bird. And we looked outside, and up in the rafters, there was a snake curled up and was right next to this bird's nest. And so the bird was just screaming at it. And so my husband's like, oh my gosh, we got to save it. There's probably babies in that nest. So I kid you not, Mel. He gets out a little step stool, and he's an Eagle Scout. So he makes this lasso out of rope, has his 22 gun, and he lassos the tail of the snake that's hanging down, pulls it down out of the rafters, and shoots the bird, or shoots the snake. And we see 2 lumps in the snake's belly. And I was like, oh no, what if it's the 2 baby birds? So my husband had in his, man cave, he had all the tools. So he gets out a scalpel, and I'm like, I got it. And I just did a neck slap on that snake. And unfortunately, I mean, who
So
you
what was
can
in the steak? The steak.
it was 2 baby birds, but they were
Oh,
already dead. They were already dead. They must have been freshly hatched because they had their feathers. They weren't like there was no like egg part around it. It was just the little baby birds. But so when I think back, to me, it was like that was one of those moments where it's like, boom, I'm going to save the babies. I, do I guess it's called a necropsy. I don't even know.
yeah.
I do the X flap. I open up the snake's abdomen or whatever it's called, cloaca. I don't know. And hear these 2 baby birds. And then we're like, oh man, couldn't save them or whatever. But thinking back now, it's like the anatomy was so familiar to me. I understood it. Not that I understood the snake parts, but I wasn't afraid of a scalpel and opening something up and exploring anatomy. That was something that was exciting to me, and I understood that. And so I think that factored into me choosing surgery for sure.
Yeah. And what was your training like? Because you were a little bit older as
Right,
the
right.
training.
Yes. So at that point, entering med school, I think I entered med school at 32. I think I got into med school at 32, graduated at 36. Med school is actually pretty. pretty straightforward for me. Believe it or not, it was easier for me than nursing school. I mean, it was tough as far as more hours to study, more things to learn, but the all the extra stressors were not the same as in nursing school. Nursing school is very dog eat dog. It was very not build each other up. There was a lot of camaraderie in medical school for me, I felt. And so that was, I got to enjoy filling myself with all the knowledge that I needed to fill myself with.
Well,
So
almost
that was actually
like
pleasant.
less drama, maybe.
Yes,
Okay.
yes, much less drama, just straightforward. Everybody's in the same boat. You're learning hard, you're going at it, and everybody's kind of, there's just a lot more people that are doing it the same way and that want to succeed. And that just felt more like a community. Yeah, for sure. But then once I figured out I wanted surgery, I felt very protected. I felt very supported. My When I was doing my biggest, longest general surgery rotation, it was what, 4 weeks or more of just general surgery. And the chief resident that I worked with was a woman, and she was hardcore and she was so kind and supportive. And she challenged me. She knew when to give me a big project, when to push me forward. And that was so wonderful and so inspiring. And so in medical school, all of my exposure to surgery, to women in surgery, was very strong, very supportive, very you got this, very inspire you forward. So I entered very bright eyed and bushy tailed the world of surgical residency. And then it came to a screeching halt. No, that's a little over dramatizing, but truly, I, for the first time, experienced what my husband was always telling me about surgery just being toxic. He's an anesthesiologist by trade. And so he was very supported in his anesthesia training, but he saw the surgical training. And, his challenge to me in med school was not to choose anything surgical. But when he saw me fall in love with it, he was supportive. But I had still never seen it myself. And so when I got into surgery residency, then I saw more of what he was talking about, the toxicity and the lack of support that, you and I have talked about and that we hear so often from our surgical colleagues.
Yeah. Well, what was your specific flavor of toxicity that you experienced?
It was from the female surgeons in our leadership. And that was very, disappointing to me, I think, because I was taken by surprise at that. I was under the, misconception that the women would support each other and that there was a sisterhood. And so I definitely was blindsided by the toxic nature of the women in the surgery program, actually. And, that led me to actually transferring to a different program to finish. And I was led to believe that I would never finish. I would never become fellowship trained. I would never be able to work as a trauma surgeon and get into a level one trauma center. And this is coming from people who are my mentors, people who were supposed to be teaching me and supporting me. And I just couldn't understand. I was not of the, personally, it was not in my moral compass to tear somebody down, to be negative and harmful. That's not a part of my core. I'm an encouraging person. I'm a supporting person. I'm an inspiring person. And it was very confusing to me why people who were actually getting paid to train me would choose this language, would choose this MO. It's like, isn't that kind of opposite of what you're here to do, what you're actually getting paid to do? They seem miserable. Most of my attendings just seem miserable.
Yeah, and it
I
kind
thought,
of speaks to the capacity that one has and how people show us how their brain works, where if they're going to talk to trainees a certain way, we know how they're talking to themselves
oh,
inside
for
their own
sure.
head.
Yeah.
And of course that's going to be they're going to have a miserable existence if they're happy people aren't mean to other people.
Right.
When
Right.
I was really burnt out and mean, when I was awful, like I wasn't kind to myself, and it was took my own self-compassion. Like Michelle Chestovich talks about how compassion is incomplete if you don't have self-compassion. And so it's
Mm,
like we think of compassion as this like limited resource, but it's really limitless, and we can have it for everybody. And it's something that like surgical training really needs like a heavy dose of. We think that we have to criticize and
yeah.
play the zero sum game and be perfectionists in order to do well at our jobs, but honestly, it just makes it harder. But
Yeah.
I had one of my friend and colleagues on the podcast talking about how she was kicked out of our residency program. I lived it. I was a fifth year, she was a third year, and I stood up for her and tried to support her, but there was only a couple of us that kind of stood up against the program and said, like, what are you doing? Like, we have to support her. We have to help her. But they fired her and she went on to get another spot. And now she is an associate professor. So, like, she's climbing the academic ladder and she's trying to make change from within. And so she's like, she's killing it. Like, she's succeeding. And it's fascinating that the story that our program told themselves was, oh, we have to protect the public. And so I'm wondering when you left, if you're willing to talk about it, was it your choice or was
No, no,
okay?
no. I was fired from that program. I was under the misunderstanding that if I shone light on the brokenness, the toxicity, the harm to residents, that it would get fixed. But that's not what happens. Not the way it is now. It's like whack-a-mole.
Yeah.
You lift your head up to say, hey guys, this is actually not helpful. This is harmful.
Yeah.
You're the one who's damaged. You're the one who's damaged. So that was a very difficult wake up call for me. I did have a friend at that time say, get out while you can. And I chose to stay and try to fight because I thought that you could use truth and logic and first do no harm and all of that. And that's not true. That's not the way it is set up right now. The way it's set up right now is for those in power who want to retain power, very much like politics. They can use whatever measures that they want, including lying, including manipulation, including power tripping and guilt tripping people. They all methods. And I think it stems from what you mentioned earlier. It's like a lot of people that are in, a lot of surgeons that are in positions of power are not fully actualized adults. Their emotional incapacity is very, very visible, not to them,
Yeah.
but to anyone on the outside that does have that emotional intelligence. It almost, in a way, now when I look back at these people who, were the villains in my story, I see them much differently now, especially the main perpetrator. I see her much differently now. I see her as a broken person. I see her as someone who always had an inferiority complex. And I think of that now when I think of different things that she would say to me. It's like, wow, it's so obvious now that there was something in her that was lacking. She felt challenged by, my confidence. I was older than the rest of them. I didn't have, I had that ability. I knew myself to a degree. Now I had so much more to learn over the years that followed surgical training. But even at that time, it's like I had lived in the world outside of academia. And so I had developed some introspection to a point anyways, and some emotional development. And so that was very unusual, very strange, to see all those people in that light. It
Yeah.
was disappointing to see people that I knew and trusted and held on such a high standard, and to watch them break and crumble when put to the test. Watch people backtrack on things they had said, watch people that you thought were of high quality actually lie. It was very disappointing looking at it from an anthropologic standpoint, to see humans are so weak in reality. We're so weak. And if you don't have that sense of who you are and what your core is, what your moral compass is, you can get pushed by some winds, you can get pushed by some storms, and it may surprise you.
Yeah, that's so interesting that you say that. And you've heard of the drama triangle, right?
I'm not sure.
Okay. Well, what you're describing is you like you said, the villain in my story in the drama triangle, there are three components. There's the hero, the victim, and the
Yes,
villain. Yeah.
yes.
And the reframes to the empowerment dynamic, this brilliant guy named David Emerald talks about something called the empowerment dynamic, where the victim becomes the creator, the villain becomes the challenger, and the hero becomes the coach. And so in your story, your villain became a challenger, and the challenger always shows the creator, because you're no longer a victim, you're a creator,
Mhm.
what they value. And
Yeah.
if we think of your program, it's like, oh, I value emotional intelligence. I value respect. I value treating human beings kindly.
Yeah, 1,000%. You know
Yeah.
what's crazy, Mel? One of the biggest criticisms against me at that time was that I was too nice to be a surgeon. First, they said I was
How dare
too
you?
much of a nurse to be a surgeon. Yeah, but it ended up getting transitioned to too nice to be a surgeon. And I thought, thank you. Thank you for that compliment that, you know, don't mistake my niceness for weakness. But then I know that I'm living out who I am when you can say that of me. I'll show you how you can do both. But, thank you for the compliment of letting me know that my true character comes out in my day-to-day life. That's a blessing.
Yeah. And it's these thought errors or these misconceptions that you have to be an asshole to be a surgeon, or you have to give up your life. You have to have one singular identity that is all encompassed by surgery.
Mhm.
And that has to be everything you do. And you have to, abandon every other hobby and creative outlet that you've had. But what the truth is, and I actually had a pediatrician who's also a young adult author on talking about how when he was in medical school, he had better grades when he was doing his musical outlet and when he was writing. So it's like the creative side, we know this helps kids
Yeah.
in school. We know that when people are playing, they learn much faster. You learn a task in 10 to 20 repetitions. If you do it with play, it takes you 100 plus if you're doing it with just rote memorization, where you're just shoving it in your own brain. But we don't honor that in the profession of surgery. We don't try to diversify our identities. We're just like, no, you have to just have surgery be your one identity. And it's like, no, it should just be one of multiple.
That is so amazing that you say that. I thought of my transition. That's 1,000% how, without being so articulate, that's 1,000% what I experienced. So I had a gap year. After I got fired, I was out for a year trying to find a place to transition to, and that's a very tough process.
Yeah.
But I learned to play golf during that time. I learned to meditate. I started practicing yoga more. And interestingly, my in-service exam, once I transitioned to the other program, my in-service exam scores just went up. So, newsflash, Mel, you actually don't learn very well in a toxic environment.
Yeah. Who knew?
Who would have thought? So when I had, as you say, reached in and found my creative side, which I didn't even understand that that's what I was doing. Then when I got to the new place that actually was more supportive, and I had those outlets that you describe, now I could learn. It was such more meaningful, and not just that it was more impactful learning. I enjoyed it.
Mhm.
I found my nerd, my inner surgery nerd. It's like she flourished. And now I was realizing, oh, you know how I need to learn? It's not like something being shoved down my throat. It's I need to have like a compendium, listen to something, write something down, do questions. I need to have that multimodal ability to learn. And that's where it really sinks in. So I'm podcasting on the road as I'm driving to the hospital. Then I'm having study time where I'm writing something down as I'm reading it, so I just learned to be a much more effective learner during that time. But it took getting away from the toxicity, having that creative brain be a part of my life again, have hobbies again. And then I was able to flourish as a surgeon from a didactic standpoint. So, but something else you brought up about, we only learn it's like a one size fits all when we're in academia. I thought the same thing. So I thought, well, I have to, go to a level one trauma center. I have to be an academic surgeon. That's the only thing. First of all, we get made to believe that that's the only thing of value, and that, definitely people were always talked down about if they were private practice, always demeaned, oh, they're just private practice. There was just a denigration of anybody else that doesn't do it the academic way. And so that's the mindset I had, even in transitioning over to my new program. And so I had gotten outside the match, actually. I had secured a place for my trauma fellowship. And so so you do, you apply and get into trauma fellowship in your fourth year of general surgery. And then you still have to go through, it's kind of like halfway through fourth year that happens. And so you have to finish fourth year and then do fifth year before you get into your fellowship. So I thought this is what I wanted to do, be a trauma surgeon in a academic center, level one trauma center. And so I strangely asked for the position outside of the match and was granted it, which was an amazing blessing and a huge compliment. But then when I was, finishing up my fourth year and then starting my fifth year, I started rotating out at other smaller hospitals, working with the community surgeons, and I fell in love. I really liked the setting where you have a relationship with the hospitalist on staff. There's good communication. It's more of a family oriented atmosphere, and you have your patients that you follow, and it just I loved that community surgery aspect. And I thought, oh dang, I'm already signed up to do fellowship, but I don't think that I want to do academia anymore. But I didn't want to let down my program director who, felt like gifted me this position. And so I stayed on and I did the fellowship, and I'm glad I did. It makes you more marketable. I do now work as a trauma surgeon with the level one trauma center part-time. So I keep my toes wet with the academia, teaching residents at the level one trauma center, one of them in Dallas. And I love that. Truly. I'm grateful for that. So I'm really glad I did the fellowship. It was trauma, surgical, critical care. So I learned so much that helps me in my day-to-day practice for sure. But then I get to be a private practice surgeon and have my, bougie little boutique surgery clinic. And, there's pink and plants and, spa music and all the fun things that my patients feel very comfortable and at home. And I like that too.
So, how did you figure out how you were going to practice? Because it sounds like you have multiple things going on. Like you have
Oh yes,
part-time,
diversifying.
yeah, yeah, you diversified. And I think we do think there's only three practice models. We're like, okay, I'm going to be employed. I'm going to go into private, or I'm going to go into academics. Like those are my, I have to choose from one of those three options, but it sounds like you made your own. And I totally agree. I think we can create our own destiny. We can choose our own path. So how did you figure out that you could do that?
That was actually through another crisis. So I started, transitioning my mindset from wanting to be in an academic setting to wanting to be a community surgeon as I was finishing fellowship. And so my husband and I were, figuring out where in the country we wanted to be and narrowed it down to a few states. And looked at positions that were open and, did the interview path and all of that. And so the position that I wanted was at a level two trauma center in a more rural setting. And I thought that would be a nice little mix of having trauma, but then also being able to have my own patients. It was an employed position, but I thought that that was going to be a nice mix of what I wanted. And so I got that position. We moved, the family cross country and started the practice and ran headlong into another toxic surgery program. This time, even though I was an attending, I was smack dab in the middle of a very similar situation where, misogynistic men, people that don't tell the truth, people that are unkind to patients and staff, let alone partners. And that was very shocking to me. I definitely had walked into that again, bright-eyed and bushy-tailed. You'd think I would have learned, but very much, I think that, I believe people, when I meet them, I believe people. And so I didn't think beyond what I was being told when I got the position. And so I was there for only 9 months and lost my contract. And that was a very shocking thing because I never had a complaint lodged against me. I never had a bad patient outcome situation. I was actually well loved by all the hospital staff and nurses that I worked with and my clinic staff. I just had an issue with one of the partners, and he was a very toxic person. And nobody wanted to stand up. It was just the same version of the story that I dealt with in residency. It was a man this time and not a woman, but the same power struggles, the same guilt tripping of people. And so, unfortunately, he was instrumental in me losing my position. And that was very shocking for me, very shocking. I didn't even know that was possible. I didn't read the fine print of my contract where they said that they can terminate you without cause. So, no, there was no problem with me. No, there was no issues. Yes, I was well loved. And yet still I lost my job because someone wanted me to. And that was surprising. Read the fine print, y'all.
Yeah, and you're not the first person who's told me that. I've heard of a lot of that happening a lot all
Mhm.
over the country and always to women.
Mhm. Yeah. So I didn't realize that they had done this to other people before me.
Okay.
I wish I had known that because then I, obviously would have looked twice. But that's their MO. That's how they handle things. And now I know, but I also know now I never want to be in that position again. I never want to be beholden to someone. I never want to be at their mercy like that. I didn't come all this way and do a residency and a fellowship and spend the best years of my life training for one of the hardest positions that you can have to be treated so poorly, so egregiously, so unprofessionally. And it was the same thing. The same thing was said to me by the people in the other departments as when I was in residency and when I was in this new job. They said, "Hey, everybody knows that your surgery department is toxic. Everybody knows X is a terrible person." They have terrible nicknames for the person in residency that was the villain in that story. They had terrible nicknames for the villain in this my story, in my first job. And it's just so surprising to me. It's like, how can people just accept this? Ultimately, the worst part of it to me is that patient harm happens. That's the worst part of it to me. Is like, okay, say what you want to me, call me names, not like my pink chair and my, big earrings and whatever. Have whatever judgment you want against me being too nice. But when you then go and there's poor patient care, you know, come on, man. This should be unacceptable. We should hold ourselves to such a high standard that yes, our niceness is a demonstration of how we treat people in the operating room, of how we treat people on the floor, of how we treat family, of how we treat dogs. You know what I mean? It's like the old, phrase when, if you're dating, the way to figure out if who you're dating is a good person is when they're taking you on a date, see how they interact with the wait staff.
Mhm.
It's like one of those things.
Yeah,
It's
totally.
like how do you treat the nurses? How do you treat the patients in the hallway? I was horrified by this person I heard at a time when I was not on call and he was covering call. One of my patients, sweet little lady, had called in to ask a question, and she was horrified at how he interacted with her,
Mm.
what he said to her on the phone, and it made me so upset. It's like, how can you do that to a little old lady? But that goes back to what we figure out now. What that villain in that story of my life, I now see him differently. I now see that he's a broken person. He
Yeah.
is not happy with himself. I don't even know if he knows himself. And so now I come from a place of, really empathy. Like, seems like such a sad place to be inside his skin.
Yeah.
And
Well, what was, if you're able to elaborate, what patient care issues did you see?
so, unfortunately, this particular person I've seen many complications of his surgeries, many complications. And that was very disturbing to me because patient harm is the top thing. Absolutely. Absolutely top to me. The first do no harm. I take it so seriously. I tattooed it on my arm.
Wow.
So that's a very, to me, I think of it as I feel so privileged to be doing what I'm doing that I best make sure I'm not hurting somebody who's somebody's wife, husband, sister, father. Like, that's a very, very special position that we hold. And, seeing some of the trainees or even attendings that treat it like a job, I'm not a fan of that term. Being a surgeon is just a job. That's just what I do. That's not who I am. Personally, that hits me the wrong way because I think that it might send a message that is lacking in ownership in what we do to a degree. I'm not saying I have that right. It's something that I'm definitely open to talking about. But if you pin me down right now, I'd say being a surgeon is a a big component of who I am as a person because I chose surgery because of how I am as a person. There's a lot of those things that are intertwined. And I think if I see my job as a surgeon as a 9 to 5, I miss a lot of those aspects that make me a good surgeon. I think I miss a lot of those components of me. If I
Yeah.
just say that's just a 9 to 5 for me.
That's so interesting because I know exactly what you're talking about. And I remember feeling the shift. Like I remember feeling as like a trainee and how we would joke about like, for example, there were rival gangs in the ICU. And one of my co-residents got in trouble because he like took a picture of one of the gang members and said he looked like, I don't know, some actor or something. But it was like we were almost like dehumanizing the patients because
Mm,
very few of them spoke English. That we felt almost like we weren't one of them, right? They're not us. Like they're
yeah.
a different species or something because you just can't empathize or see yourself
Tell,
in their face, right?
tell you, yeah.
And so you get to this place where you're almost so detached, you're dehumanizing the people you're taking care of. And that's, I think, where you can get to a place of, oh, this is just a job. This is just what I do. And I felt that. And I could feel how everybody's just like, I want to do the really hard cases. And it was almost like they're doing surgery for them as a trainee, or like, I want to do the surgery for me so that I can learn the skill. It's not to help this patient, it's not in service to this patient. But then it swings the other direction. And I felt the swing when I got out on my own. And I was like, oh, I'm overly attaching to outcomes because I'm terrified of hurting someone. I care too much, especially with children after I had my own kids.
Oh,
I was like, I can't detach at all with children.
mm,
I just see my kids in the faces of these children that I'm supposed to operate on. And so I can see like how the pendulum can swing both ways
ah,
and both ways are bad, but there's
yeah,
a middle ground where you're
yeah.
like strategically detached. And I love how Brad Stulberg, who's an author and a personal development coach, and he writes about this in this book called The Way of Excellence, which is it's not out yet. It'll be out in January, and I'll have him on the podcast. But he talks about how setting a goal requires us to kind of go through these specific steps. And the first thing is to set the goal. And in our minds as surgeons, a lot of us set goals that are not the correct goal. Like, for example, in orthopedics, they try to go for anafucking or AFT, where they're like trying to get the bone perfectly aligned. But that's not really the goal. The patient doesn't care if their bone is AFT. The patient wants to walk without a limp. So, like, we
Yeah.
forget the goal is actually to get this patient functional and you have this shared vision. Like, if you're in trauma, it's like, well, I want to save life or limb. If you're
Mhm.
in plastic surgery, you're like, well, 80% improvement in your appearance. We agree upon a shared goal, and that is the goal. And it has nothing to do with how perfectly you execute. You're just doing the best in service to the patient to get to that shared vision. And then the next step is to plan and prepare every single step ahead of time. So that's all of the studying and the training that we do. And it's like, okay, to get this patient walking without a limp, I have to fix their hip, right? I have to give them a hip. I know all of the steps for a hip replacement. And then the next step is to forget about the goal, where you
Huh.
drop it, where you are no longer thinking of the goal and you're just looking at the step in front of you, where it's like, okay, now I approach. Now it's incision. Okay, now I access here. Okay, now I do it here. And you're not thinking about the end result. And that is paradoxically how we create the best surgical outcomes. And it's how like performance athletes do it. Like you don't have a golfer who's on hole two in the Masters. He's not thinking of the 18th
Yeah.
hole. He's not thinking of what he's going to do there because he's like, I'm just on this hole. And that's all. And I used to do that as a marathon runner. I was like, if I thought 26 miles, I would get overwhelmed and I would feel like I wouldn't be able to like show up to that mile. It was like, I'm just at this mile. And I don't think we're not given that mindset. And so we get very confused and we watch the humans just pendulate to like to overly attached or detached or somewhere in between. And we're like, I don't know which one I'm supposed to do, but the stakes are so high and I could hurt people. And what do I do? So it's so interesting that you just saw like the whole gamut of all of that.
Oh, yeah. I'll tell you, community surgery is, I think, the way that I have found balance, like you saying, truly. How I got there was so circuitous, but a big influence on figuring that out, that balance that you're describing, which I think is in my mind, what popped in my mind when you were describing that is mastery. I feel
Yeah,
like that is
mastery.
mastery, that's
Yeah.
surgical mastery. So one impact on developing this mindset, which I did not expect, was doing a lot of palliative medicine when I was in fellowship.
Really?
That was that was very amazing. It was, obviously at times it was very depressing, and at times it was very rewarding. But I will tell you what, developing my ability to have those difficult talks that we all have to have all the time on a palliative medicine level in trauma ICU, boy, that was staying out of my comfort zone. Sitting there time after time after time with all these families, multiple family members, and props to my attendings because they were so intuitive about what I was looking for and what I was hoping to gain from my training. And so they just let me go. So it would be the palliative medicine doctor who was, the like a non-surgeon palliative medicine doctor, and myself, or it was their nurse practitioner and myself and the family. And so I would be the connection, the conduit of the all the surgeons and ICU people. And as yes, I was fully trained surgeon, but now in fellowship, that was so impactful to sit there time after time after time for a year, having these conversations very frequently. It just helped me to understand what the value was in their family.
Yeah.
Very rarely, if you got to the nuts and bolts of it, was it quantity of time. Very rarely. Most of the time, it was getting back their quality of life, the quality of the time that they had, whether it was going to be, very temporal in the ICU and they just wanted to, pull the tubes out and just be able to kiss their face and talk to them. Or if it was like, no, we want to push forward and be able to get them home and have some semblance of independence, and how can we do that? But it almost always was the quality that they were going for. And so I didn't even realize how much that was weighing in my mind and how much that was training me. And I took that with me into my community practice, after the debacle of employed status, into my community practice. And so my goal with my patients is to have their quality of life. So, that really helps to shape the way I practice. So I do a lot of lifestyle medicine teaching with my patients, even if they come to me for just a gallbladder. We're going to talk about the smoking and the impact. I have a big book, one of the big atlas books where it describes, it has cross sections of, a blood vessel with, filled with plaque, and it has the, pictures of the anatomy that's affected with, the presence of smoking. And so it's much more of a, total body discussion, because not only is that so impactful for healing from surgery, but if they're going to come to me and then they're going to leave our experience and have a better quality of life, the obligation is with me to help give my knowledge over in layperson form so that this can really be a life-altering, positive life-altering interaction.
Yeah, well, it sounds like you're treating like the whole human being. And that is kind of rehumanizing. If you think of what humanization is, it's seeing people as a whole. And I think there's an epidemic of just dehumanization in the profession of surgery because we do distill people down to a disease process or to a body part. It's like they're a gallbladder or
Right.
they're a broken femur or whatever it is.
Mhm.
And we fail to see the whole human. And it sounds like you had the opportunity that none of us get, which is amazing. I would love to be at the bedside. I would love to do some sort of palliative fellowship. I think palliative care is the most fascinating thing in my mind because it really shows what matters. I'm always thinking, this is a very stoicism exercise, but I'm always thinking, what if I'm on my deathbed, what matters to me? If you reverse engineer from like the end of your life, you start to see what you truly value. And so you got to sit with people who were actually facing death and they had to say what they truly valued. And they're not like, yeah, having more time isn't that great if I'm going to be all with these tubes and this, like, all the beeping and in this hospital. I'd rather have less time and be with my family at
Yeah.
home, somewhere where I'm
1,000%.
comfortable.
It's not natural for us, I think, as Americans. I remember when, before all of this, when my husband and I had first gotten together, we hadn't been married long, he always wanted to talk to me about, hey, if anything ever happens to me, pull the plug kind of thing. And I would get angry at him.
Mhm.
This is morbid. Stop talking about this, please, as if we're going to live forever,
Like you're gonna make it happen though.
yeah. But it was just not built into my family,
Yeah.
the way that my family communicated. It wasn't built into education at all. And I had been through so much education. So it was only after I was able to see like this. I was able to see it from the perspective of, like you said, reverse engineering your life. And then I was open to my husband having these discussions. And then I wanted to know how I felt, I wanted to know how he
Yeah.
felt. And, it was so much more effective and helpful that we could truly know our value system and be able to communicate that with each other. But it's only because I was exposed to that degree of that level of training. But it was interesting just how all of that, all those experiences, you could consider them failures if you looked at, check boxes, or, success, fail, more from like a black and white perspective. But I see those failures as being a part of my story, and taking away from them those positive aspects to see how it altered who I was, how it opened my mind to who I am. Then I see that they're becoming part of my strengths. They're becoming part of me getting to the core of who I am and what I truly want and what I truly need to be able to be restored and to be able to be my best self, which only impacts the world around me for the better and for the positive.
Yeah, and
But
you can deliver care as a surgeon even though you went through a non-traditional track and you wear hoopy earrings and you like pink and you're nice. Isn't that amazing? Like,
yeah,
but it's weird that the system kept telling you like those two things are mutually exclusive. Like you can't, you got to like toughen up or whatever. You got to get rid of the pink
mhm,
and then you'll be successful. But that's again, that's another thought error that the system seems to perpetuate where you have to fit this avatar of the ideal surgeon, which is very male, very white, and has a wife at home and commits 100% to the hospital and lives there. But you can actually do it however you want, and you can be female, you can come from any background. It doesn't, it's actually better for the profession the more diversified our profession is. And
1000%.
yeah, so
We have to be true to ourselves.
yeah.
Yeah.
How did you come to that conclusion that you're like, okay, I'm going to be a better doctor if I'm true to myself and I
Yeah.
don't listen to what culture keeps trying to shove down my throat?
Yeah. I don't know, except that it was an amalgamation of all of the above. It was understanding that the people who are telling me these things, you've heard that phrase where don't go ask somebody for advice. What is the phrase? I always mess this up. That is like, if you don't respect their opinion, don't ask their advice. Or if you don't, trying to say there was a
Yeah,
phrase
yeah.
out there that I can't remember,
No, I
but
think I
it's
know what you're
something
saying.
like
Yeah.
that. Yeah. And so, in other words, look to the source. Is this source, whoever's telling me these awful things, do I even value that person?
Yeah.
Do I even value, are they even exemplifying who I want to be? If no, well, then the quality of their advice just became absolute, you
Yeah.
know?
Yeah.
And so recognizing that helped me to see, okay, I don't need to listen to everything that comes into my brain. I need to listen to that which, rings true based on what my value system is. And so hearing those things like I'm too nice to be a surgeon, being able to take that and actually flip it around and let it be a compliment.
Hmm.
That was very powerful for me, I think. And then at the next place, the plants are, too much, the pink is too much, the, skirt, or, whatever it is, that the long earrings, whatever. When you step back and look at that 30,000 foot view, it's they're not comfortable with themselves, or maybe they have something, in their background that, with my personal sex, that's not comfortable for them. This particular person had a tumultuous relationship, a new divorce, all these things. So it's like they potentially are going through something that they're not able to recognize and accept me as a feminine, woman. And this person would, at the my first job, this person would always berate the girls that were my medical students, telling them, you shouldn't go into surgery. You're only going to last 5 years. Very, very denigrating things about women in surgery. And so, being able to kind of get some thick skin and realize, what, if we're going to make change in this environment, in this industry, we're going to have to all be solid in ourselves. When you look back at the women who were older surgeons in my training, they were almost only one type. They were very harsh. They were very, You know what I think? If you think about it, it's like they had to go through fire. They were the
Mhm.
original girls. You know, they conformed.
They
They
were
didn't
hard.
stand out. Yeah, they had to be tough, or at least that's what they chose, I should say. I didn't go through that. They did, but it seems that that was how a lot of them were at that time. And now I think I hope we're understanding more that when we allow someone to be their authentic self, when we celebrate that, and when we realize that our diversity is our strength, because not everybody's going to have the same experiences, the same personality, and our patients are like that. They're all very different. And so, yeah, I have a lot of girls that come to me because I'm the only girl surgeon in town. And a lot of times they feel more comfortable with me. But I've got a lot of guys too. They just like the fact that I can explain things very
Yeah.
well, that I can describe the surgery, and they're like, wow, nobody's ever described it to me that clearly. I understand what you're saying. So you may think that's because I'm a girl and we're good communicators. And so we are very detail oriented. And that may be why it is. There may be plenty of men that do it that way. But, being able to just be comfortable with that and understand that about myself and be able to honor that about myself has just become so much more comfortable.
Yeah, what you're describing is positioning, and we don't talk about that in our training. Like if I had to think about my own branding or marketing or selling myself as a doctor, how I would position myself, I would have never said I was going to position myself as like the ego in the white coat. I'm up here, I have all the answers, I'm in a suit, and I'll just shove all my knowledge down your throat. Patient, I was always the like girl next door. Like people always want to hug me. My patients are always wanting to hug me, and I was just like this cute thing that's like on your level. I just have a knowledge of something that more than you do, and I have a set of skills that might solve your problem. And so that was always my positioning, but I had to kind of like figure that out as I went through. But it would be useful to have medical students and residents and think about like, how do I want to position myself? Do I want to be a girl next door in scrubs and I'm just everybody's best friend? Or do I want to be more of the authority? Because some people
Yeah.
like that. Some people like the, hey, you have all the answers, you tell me what to do. I'm more of like, let's collaborate and figure this out. And you have the answers within you. I'm not the one who's I'm not the CEO of your life. You are.
Yeah.
But yeah.
Think about, how do we get there? How do we get there, Mel? I think that it requires a lot of introspection. We have to know what our core is
Oh
to
yeah.
be able to pick that, to be able to choose how do we want to show up as a surgeon. It's like we have to understand what makes us tick. And what I know about myself now, where my true, center is, my core, is very different than I thought it was 8, 10 years ago. Very different. And it's so interesting in getting there. So I thought I was the rocker chick. My brother, it was he still is a lead of a band. He's the lead singer of a band. It's, small time, but like good musician, all of that. And so it was really fun when I was in my young adult years. He was, the front man for his band. And so I would go and watch him play live, and enjoyed kind of being in that rocker chick stage. And so I thought I was, the one who wanted loud, crazy music and, adrenaline junkie kind of thing. And I don't know if it was just that was the time of my life, or if it was me not understanding what gave me restoration, but what restores me as a person and in my soul now, I know, is peace and calm, not being up till midnight, but actually going to bed really early. This may just be because, I'm older, but I want to see the sunrise, with a cup of coffee, and in finding out what makes me feel whole and what makes me feel the happiest version of myself. That's where I show up better for my patients and my practice. So it's like this whole encompassing um, presentation of Mandy in her world,
Yeah.
and you can only do that when you know who you are. You know the character that is in the story.
Yeah, and you know that that character is going to evolve and change and grow. We don't just have these milestones that we reach as children. We reach milestones through our life,
Yeah.
all the way until we die and start to prepare what is our legacy going to be. So it's almost like we forget that we're not static, we're ever
Yeah.
evolving. But the system wants us to just stay static and just live the dreams of like our our college selves. But it's
Yeah.
like, no, our values change. When we have children, our values change. As we get older, our values will change. And so what, what we're the resident version of ourselves is not going to be the same as the attending version of ourselves. And that attending is going to continue to evolve and change. And we need to have
You hit
space
the
for that.
Yeah, you hit the nail on the head. Thinking back at the attendings that trained me, I didn't like the fact that they all seemed upset, you know, burned out, hated their lives. Nobody wanted to learn anything new. I like to use the robot. I use the Da Vinci robot for all my big cases in the abdomen and pelvis, and it takes a lot of extra training. It's very hard to use. And none of my, none of the trauma emergency general surgeons in my training wanted to use it. They were all very against it because, think about it. To learn something new requires getting out of your comfort zone,
Yep.
being vulnerable,
Being bad
being
at it.
being okay with failing,
Hmm.
being okay with, yeah, with being bad for a while at it, and giving yourself grace to learn and train. But that is the difference, I think, of me and a lot of other people in that sense, is like just what you described. And I know that you're the same way. I have an aversion to stagnation, an aversion to it. It comes from way back in my childhood, childhood trauma stuff. Hate the idea of those four walls closing in on me, and hate the idea of being small minded and not learning and not growing. I mean, look at the world around us. It's beautiful. We're always learning. That student of life is a reality. That's part of my core, is that curiosity. That's why I married the man I married, because he's just like that too. Is like always wanting to learn, always wanting to try, always wanting to consider something, and being open to new experiences. And I think that's a huge part of being alive,
Yeah.
truly alive.
Yeah. No, you're so right. And it's like there's a childlike nature to it too that you have, which
Yeah,
is it keeps you young, I'm sure.
for sure. For sure. Yeah,
Yeah. Well, in
absolutely.
closing, tell us a little
Yeah.
bit about how you got into direct care and how that journey's gone.
So my husband could probably speak better to this, but the idea that our system is broken,
Oh,
our
totally.
healthcare system is absolutely broken. Insurance is terrible. That's come so much more to the surface with me being private practice now, because I have to call the insurance companies for prior authorization, and that always makes me just cringe, because I'm
Same.
asking them, "Hey, will you continue to support the person that gives you money for their premiums every single month? If I do this like life-saving thing, like take out something in their body that's trying to kill them, please cover." So that was really frustrating to deal with, and my husband is extremely averse to that, to just utilizing the insurance altogether. And so
Yeah,
we named our
it's a moral
practice.
injury, you know?
Oh yeah, it's 1,000%
Yeah.
more injury. So we named our practice Direct Surgical Care, in the hopes that we would be able to, not utilize insurance at some point. But we're in a rural part of Arkansas, and so people don't necessarily have the means to be able to pay cash, or at least that's what we were thinking initially. So we abandoned the hope of the direct care. But then I started learning more about women's health, because I was finding a very consistent theme of damage to women's bodies when I was, going to operate on them. And the consistent theme that they finally figured out was that they were lacking their hormone replacements after they had gone through menopause and had ovarian failure, and didn't realize the impact on, bones, muscles, heart, the genital urinary structures. It was pretty amazing. And so I was walking through it myself, seeing all of my patients, my female patients, walking through it. And so that opened up a whole new frame of mind, again, being open to learning something new. So I got certified in menopause care by the Menopause Society, and now we're opening this branch. So it's called Direct Integrative Health, but it's our midlife women's care. So lifestyle coaching, hormone replacement, doing it natural, bioidentical, not doing stabbing pellets in their back kind of thing, but like actually like what is going on with your symptoms, where are you at, and just getting down to the nitty gritty of their body, their symptoms, their exposures, and helping them to, again, goes right back to the quality of life. So if you come see me, I want to help get you back to the quality of life that will give you all the goodness out of your life that you're looking for.
I love
And
that.
so it's just kind of a natural progression that I never would have expected. So I'm a surgeon and a midlife specialist. Who knew?
That's so cool. Yeah, you're adding more life to years, not yeah,
Yeah.
adding more years to the life. That's so
Yeah.
cool. Well, if anybody's listening to your story and they would like to reach out to you, would you be willing
Oh
to
gosh, absolutely.
mentor? Okay. How can people find you?
So I am now my husband's getting me a drmandyrice.com website. So you can try that for sure. But I'm on Instagram, either under Direct Surgical Care of Hot Springs on Instagram and Facebook, or I think it's Mandy L Rice on Instagram for my private, and my name Mandy Rice under Facebook also.
Mm,
And then email, I think the best one would be mandyrice.do@gmail.com.
I love it. Thank you so much for coming on and telling us your story. I really appreciate it.
Absolutely. Thank you for having me.